Yeah. Flight is just 30-40 minutes.
So Tanu, are we live now?
No, madam, not yet.
Yeah.
Everything is ready. I think we can start.
No, she has to go live first. Let her go.
I think we are already streaming because I got a message on my screen saying that we are.
But
Okay, so maybe it hasn't started at the other end.
Hasn't started yet.
Yeah. How bad is the COVID thing in Kerala now? Is it settling down?
Kerala
No.
is
Top level. TPR rate is 50%.
We're always top.
Always.
No, but it picked up later. Like other places did it. I mean, we had much.
We have a starting problem. After that, we will be at the top. Now it is 50, TPR 50% and daily more than 50,000 cases also.
Yes, madam, we are live, ma'am.
Tanu, we can start, huh? Tanu?
Yes, ma'am, we can start, ma'am.
Good evening, all of you. This year's first TACO monthly evening program. We are very proud to have and very honored to have with us Dr. Gaurav Luthra, who is the director of Drishti Eye Institute, a very good friend and a past classmate and batchmate of mine. So very happy to see you here. And he's now a national and international speaker on refractive surgeries. He's right now the AARC chairman of IRRSA. And before I start doing that, I will have an introduction by Dr. Sri Lakshmi from Eye Vision Hospital. Please introduce the speaker.
Yes, ma'am. Am I audible, ma'am?
Yes, you're audible, please.
Okay, ma'am. Thank you, ma'am. A very good evening to one and all of you. We are lucky to have an eminent speaker with us today and enlightened to Dr. Luthra, fraternity and an internationally research. The director of Drishti Eye Institute, Dehradun, a pioneer in the field of cataract and refractive surgery. Maulana Azad Medical College, New Delhi. His primary areas of interest are pediatric and challenging cataract surgery, new technology IOLs, keratoconus, and refractive surgery. Sir has served many prestigious positions in various ophthalmological societies. At present, he is the chairman of Intraocular Implant and Refractive Society of India, president of Dehradun Ophthalmological Society, member Scientific Committee and Management Committee of All India Ophthalmological Society. Dr. Luthra has been a recipient of numerous awards, including the Distinguished IARSI Gold Medal, Subodh Agarwal Gold Medal, and many more. He is the founder and chief instructor of tech skill transfer courses of AAOS since 2003. Sir has also done contributions to various activities. He was of many premier conferences, presented over 100 papers at international platform and over 200 papers at national level platforms. He has also been an invited faculty at American Society, European Society, American Academy of Ophthalmology, World Ophthalmology Congress, Asia Pacific Academy of Ophthalmology, besides several national societies. Sir has performed challenging live surgeries, over 100 workshops in India and abroad. We are fortunate to have you here, sir. On behalf of TACO, a very warm welcome to you. Over to you, sir.
I'd like to invite Dr. Sinu and Dr. Merin and Dr. Rajendran. Please chair the session. And over to you, Gaurav.
Thank you, Dr. Sudha. I'm really grateful to TACO for inviting me today, and it's indeed an honor. And I'll be speaking on phakic lenses, which has been a passion for more than 10, 15 odd years now, and have learned a lot along the way, and I continue to learn even today. I'll share my screen in a moment. I think, is it shared now?
Yes, yes.
Yes, yes.
All right. So, phakic lenses, we've all been, doing them for several years now, and they've become more and more popular with time as we have understood better and better how the pearls and pitfalls with phakic lenses. So today, many refractive surgeons and even non-refractive surgeons, even cataract surgeons who are not even doing laser corrective surgery, are adopting phakic lenses in a big way. And one of the reasons is that now, we have wider availability of the phakic lenses as well. So from what we used to do initially, we have better variety of lenses. The Indian lenses of 2 or 3 companies are available. So the critical, reason for having an ICL, the most critical part of implanting an ICL is probably the white to white and the sizing. And while several things have been attempted for the sizing, what we use today, including the calipers and so many other things which have been explained over the years, what we typically use today is the for us, it is the calipers and the white to white measurements from the pentacam. Now, the pentacam can give white to white in 2 ways. One is from the holiday EKR report, which can show you the horizontal white to white, which comes out somewhat like this. And the other way is to use the iris image, where I'll just show you the small video clip. So what you can do is you can go to the display here and click on, for those of us who have a pentacam, otherwise the same thing is possible on a good topographer as well. Anything that captures the image and has calipers can be used to do this, except that it has to be well calibrated and you have to know that it is giving you readings which are similar to what you get with your digital calipers. So you have to just click on display, and then you can select this iris image. And once you have the iris image, it has the option of either having the limbus on or off. So if you look here, it'll show you show limbus. If you unclick it, then these markings will go away, and then you can actually use the white to white yourself. And at the bottom left is to how to choose the calipers. So once you have that, you can just select this image and then switch the limbus on or off as per your convenience. And then you can drag the calipers and you can measure the white to white like this. I have found this to be one of the most accurate ways. In last 7-8 years, I use this along with the digital calipers, and most often they coincide. So, but however, we always manage to do both these readings so that we have 2 independent readings. And if there is a difference between the 2, that means some one of the 2 is going to be wrong. So then you go back and look it up again. And this has held us in good state for our white to white measurements over the years. So this is what the iris image looks like. This is the holiday report. And on top here is the horizontal white to white. So this is another good way of, measuring the white to white. So now they're going ahead, I think, this determines whether you get the ICL sizing is what determines whether you will get a good vault or a low vault or a high vault. So anything between 250 to 750 microns is what you are trying to get. And sometimes you will get a very high vault, and this can happen if your chamber depth is less, or if you are correcting a very high correction, a very high myope, and your chamber depths are shallow. So these surprises can often happen. In the past, I remember using the UBM, and we did trial for almost a month or 2 with the UBM to measure sulcus to sulcus, which was proposed at one time to be a very accurate way, but we found that it was also very user dependent, and measurements of S2S would vary between different surgeons who were doing it. So gradually we abandoned it. Now, why ICL sizes? ICLs typically come in sizes or steps of 0.5, depending on the white to white, whereas the IPCL, which is the other lens which I use now, is having steps of 0.25. So a little more versatility there. But of course, ICL, the Star ICL, has stood the test of time, and I've been using it for almost 15 years now, or maybe a little more than that. And we find extremely good results with the ICLs, but there are patients who may not be able to afford ICLs, and over the last few years we have started using for some of our patients the IPCL as well, and they've done well as well. Now, the thing is that you may have 2 situations with the same white to white. You may have a white to white of say 11.2, or say another situation where it's 11.6. And however, what made it change the situation is if the AC depth is good or not. And also if you're using a toric ICL where the tolerance for rotation is less. So you don't want a toric ICL rotating at all. So you want a good size. So you don't want a very low vault if you're using a toric ICL, else you will have a malpositioned ICL. So essentially, in this chart on the right side, you'll be able to appreciate that if you have a 11.1. So problem arises when you have a white to white measurement between 2 devices. For example, if you use the calipers and you note it down, it has 11.1, and you use the pentacam and you got an 11.2, now you'll be in a dilemma of which one to choose between the two, because at 11.1 you would be using a recommended size of 12.1, whereas if for the 11.2 you might want to use a 12.6. So here comes help in this way. So if you have AC depth which is less than 3.5 within 11.1, you may continue to use the 12.1, and if the AC depth is good, you may continue to use a 12.6 lens. Similarly, if you had another situation where you were struggling between the 11.6 and the 12, for the recommended size of 12.6, again, here, these are the borderline cases where the AC depth can help you decide. And also sometimes I've noticed that if you're using a very high powered lens, sometimes they tend to get a very high volt. So if you're using a -18 or a -19, whereas if you're using a lower powered ICL, you will probably not get into these situations. So like this, you can switch. If you had an 11.6 wide to wide, you may want to use a 13.2 lens in this situation if the AC depth was more. So they end up finishing beyond 13. So beyond 13, it's not recommended at all. So anything less than 10.5, or if the wide to wide is more than 13, you will not want to use an ICL. So coming to some situations now, why I wanted to kind of introduce this is because I've found over the years that we all do great refractions, we do gonioscopy, and we do good case selection, and everything else we learn quite well. But sizing continues to remain a thing which we probably want to do best possible. And that's why that part, and some of these situations which I'm going to show you now, I'm going to move to the videos part so that I can show you the learning of how different things can be managed during surgery, and what I have learned over the years. And you can feel free to stop me in case anybody has any questions in between. Now, this was a situation, I'm picking out this video from 2006, where we were learning still. And you'll notice that what I'm making a mistake here is that I've made an incision of the same size as what I would make for my cataract surgery. So I used to use a 2.2 incision, and I enlarged it. If you notice this, I enlarged it to a 2.6 instead of the usual 3 mm which I should have used. So if you notice here, I made a 2.2 incision because that was a standard blade I used to use for cataract, and by mistake I used the 2.6 enlargement which I would have normally used for my some of my foldable oil implantations. And the second mistake I'm making here is, so this was basically a learning video to show what mistakes you can make. I'll just, one moment, sorry about that. So here you'll realize that the other mistake I'm making is just watch my forceps. My left hand is holding a forceps. This is terrible. These are one of the couple of first Q cases that I was doing, and I forgot that I was supposed to use a manipulator in the left hand. And I'm trying to push it in, and obviously the ICL just would not go, and it was a wound assisted injection which I was trying to do, which you can never do. So 3 pearls here: stabilize the globe with the manipulator, which all of us actually know, but sometimes you may just like I forgot, you might forget at the time of the surgery. Second thing is that you never do wound assisted, have an adequate incision of at least 3 or 3.2 millimeters. And third, no wound assisted injections, otherwise you will end up in these situations. So obviously this surgery was aborted, and then I enlarged the incision. Today, since we do a lot of ICLs now, I have sets where the standard things are there. The incision size will be always 3 mm, so that I don't make a mistake, and no wound assisted injections. And this is the correct way, where you're stabilizing the globe with the manipulator, ICL manipulator, and then making sure that your cartridge tip is on the inner aspect of the wound, not at the outer aspect. Then your ICL will go out fine. Now, if you don't do this, you can end up in situations like this one, where this was of course the loading, and let me take you to the injection part. Now, as I'm injecting the lens, I kind of feel that it's not opening the right side up. So I'm sorry about that. I'm wondering why this is happening. Some glitch there. Anyway, so this was the loading. I was trying to just cue the video, but it doesn't work and kind of keeps playing on its own. So here I'm injecting, and you'll realize that there was a little bit of hesitation as I injected, because I was trying to see if it's opening the right side up, and that little hesitation, and the cartridge tip has disengaged from the lip of that wound. So if you'll just notice this again here, just watch this. It has disengaged from the cartridge. It's just come out. This happens if you're doing a wound assisted, or if your incision size is not adequate, or if your counter pressure is not very good. So if you're using good counter pressure with your left hand, the cartridge tip will not disengage. And if it disengages for that moment, then you're stuck, because now the ICL gets stuck, and you'll have to either explant it or push it in, depending on how much has gone in. And it can put you in a mess, because it may open up inside wrong side up, and there are lots of possibilities of mistakes here. So anyway, going on, you have to manage the situation, and usually it is best to just pull the ICL out, which is not difficult at all. So here, another situation where, so the loading is, I think, the key. And this is what I wanted to show you, that the loading is probably the most important part. It should happen in one smooth motion. And after positioning the ICL here, and then you have to notice that the 3 holes are all aligned in one go. If they are not, you can just remove this and then go back and load the ICL again. Otherwise, it will definitely have a situation and it might just open upside down. Here you are noticing that I'm injecting, and again, I wanted to show you that if it gets stuck, all you have to do is just pull the ICL out and it'll just come out. Don't struggle by pushing the ICL in. You can just reload it very easily and inject. So in that rare situation where the ICL gets stuck in the wound, and it does happen, believe me, especially it happens when you are just kind of trying to see if the ICL is opening the right side up, and if your landmarks on the ICL are correct, then in that brief moment of hesitation, sometimes the ICL gets opened up inside the cartridge itself, I mean in the tunnel itself. So going on, I think another situation which you want to avoid is when sometimes when you load the ICL and you have pushed it ahead and you keep it on the tray, and then you go back after making the incisions to put in the ICL, you may have a situation where the ICL, one of the ears of the ICL is already protruding out. And here that's what was happening. And then either you can be very careful to inject it still, but see, because that had happened, this ICL is opening the wrong way. So I'll just take you back again. As I was going to inject, I noticed that there was a small protrusion of the haptic from here at the tip of the ICL. I'm so sorry about this. It's having a mind of its own without me clicking. It is. So the ICL is protruding a little bit. I decide to try and inject it. But in this situation, because there will be resistance in the section, the ICL may open in a funny way and it may rotate, and you may end up in a situation where you have a flipped ICL, which will be terrible. So again, here, as I should have aborted it and just reloaded the ICL, I was lazy. I got this situation, and then you have to manage it. So don't think that I get this often, but these are the 4 or 5 instances where I've had this over 15 years. But yes, these are learning points and what all not to do. So here, another situation now, as we are just positioning this ICL. It was injected nicely, and I'm just positioning the ICL now, and now the other foot plates. So just keep watching what happens. I get all the 4 foot plates in, and as I'm going to come out now and wash and get out of the close up, we nowadays don't use pilocarpine, but just watch what happens. Just watch what's happening here. So what's happening is I put the 4 foot plates in, and I'm going to just wash and close up, and I notice this small notch over here. So it's a peaking of the pupil. Now, if you notice this, you have to be very careful. This is usually a sign that one of the haptics has popped out and causing this pupil peaking, which you may not see very often. So if you notice this, you have to just go back and see, just see here, there's a peaking, and I'm going to look for some. It's very easy to miss one of the haptics if it's putting out, especially if you're not putting pilocarpine at the end of surgery, which we nowadays don't. So again, I realized it. And so it's good to watch out whether your pupil is round and whether all the 4 foot plates are in till the end of surgery. Else you can have a problem there. So another situation now, very often, because these ICL tunnels are a little big. So if you're making a 3, many people like to make a 3.5. Sometimes the ICL tunnel will be leaky. So you just put few drops of trypan blue. And if it's a leaky tunnel, you don't want to suture it because you'll induce astigmatism. And you can just make a supraincisional tunnel here. And this is like the Wong incision, but I have been using this also for my pediatric cataracts and all kinds of leaky wounds. You can just hydrate the roof of your incision by making a small pocket anterior to the main incision, and then check it with the Siedel's test using the trypan blue. Both these things are things that I have innovated over the last 5-8 years, and we are publishing these both. And another situation now where the ICL, so sometimes as you inject the ICL, what I was trying to show you there was that the ICL was loaded well because all 3 holes were good, but the last hole was probably looking a little bit to one side. And as you inject, sometimes the ICL will start rotating, and I'm trying to overcome that by rotating the ICL, yet it did not help. So I think there's some problem. I'm so sorry about this, but it tends to just run on its own and has a mind of its own. So as I inject, the ICL goes, and it tends to, I'm trying to rotate it so that it opens the right side up, yet it opens in a peculiar way, and you have to sometimes ensure that it opens the right way up. And I manage that by just rotating it. But frankly, the star ICL, if you rotate your cartridge or your injector, nothing seems to work. But if you do it with the IPCL, it'll work. I'll just show you now the IPCL. So here, if you notice, the IPCL is being injected, and as I inject, you have to watch out. It has its own set of landmarks. So there is a small projection towards the left of the loading leading haptic, and there are two positioning holes. So I don't know how many of you are using IPCLs regularly, but it does have those. It comes as a smart toric thing. And see, I'm watching out for the landmarks, and I'm trying to figure out whether it's the right side up. And you can rotate the IPCL halfway through the injection and even halfway towards the end of the injection if you are not sure that it's opening the right way. So you can go with a very gradual injection, and even till the end of it, you can pull it out if you want. And that's the best part about ICLs, is that even if you want to abort it at the last moment, all you have to do is just withdraw the cartridge, and most often they'll come out. So this one eventually opened the right side up, and I was able to, put it right. Another situation here where again I'm injecting the IPCL, and as it's opening up inside, I feel that it's probably not opening the right way. So I'm trying to watch whether the landmarks are correct or not, and I feel that they are not correct. So at this point, I decide to rotate it, because I suddenly realized that the IPCL is the wrong side up. So you just watch that I've already injected about 80% of it, and yet I will be able to rotate the IPCL even at this point, as I realized that it was going to open upside down. So this happens rarely, but when it happens, you have to be alert. Otherwise, you'll have an IPCL which is upside down, and you can have lots of problems with that, because you can, if you by mistake put it in that orientation, you'll create a cataract. And then, of course, otherwise, if you recognize that the landmarks are incorrect, you can just pull it out and then reimplant it. But it's always tricky to do all these things, and best to be avoiding these things by watching out for, as it injects and opens up, whether your landmarks are correct or not. So another situation here where, as we injected the ICL, it flipped, and we were in a situation. So you can watch here that I'm trying to rotate the cartridge and correct it. However, the ICL is opening in the opposite way, and it was a flipped ICL. So of course, if it's a flipped ICL, put a lot of viscoelastic, use the ICL holding forceps. You can either hold one ear of the ICL, or you can hold between the 2 ears of the ICL, or the 2 haptics, and it comes out from a 3.5 millimeters very easily. You don't have to cut it. You don't have to do anything. And then you can just go back and reload the ICL and inject it over there. It would usually then go fine. So there you can inject it. Now, here was another situation where it was an IPCL which flipped inside as we injected. So I'm trying to set the orientation right. However, in spite of my best efforts, it somehow managed to open the wrong way. So how to recognize it's opened the wrong way? Because the 2 haptics, which are 2 holes which are on the optic, should be actually superior towards you. And this small notch should have been actually over here. So this is a flipped IPCL. It's very important to recognize this. And if that happens, of course, you should then explant the IPCL. And it's as easy to explant the IPCL as it is to do it for ICLs. So put a lot of viscoelastic and bring the haptic close with the left hand and position and stabilize the IPCL, and then just pull it out. It folds up and comes out from a 3.5 millimeter incision, and just reload it and then go back and inject it. So going on, sometimes you will have, if you have a low vault, you may have a toric ICL which may rotate. If it's a spherical ICL, usually nothing will happen, but if it's a toric ICL, you will have to go back and reposition it. And if repositioning is not difficult, you can just reposition it to the same axis. But sometimes even repositioning does not help, and these ICLs will sometimes rotate back. So you have to be alert, and if they still rotate back again, then you will have to exchange the ICL. So this is very important with toric ICLs, because the tolerance is very less. I mean, if it rotates, you will have a patient with significant astigmatism. So undersized toric ICL can have situations where the ICL will rotate sometimes, and then you can have a situation. So also, if you have an undersized decentered ICL, sometimes the ICL will look like this on slit lamp, and then of course this ICL will lead to a cataract, because superiorly it may be doing an ICL, maybe touching the lens. So these ICLs need to be exchanged. And sometimes if you have a very low vault, you will have a situation. Nowadays, the tolerance for low vault has gone up, because ever since we got the center flow, the incidence of cataract has gone down drastically. So even vaults of 200 to 150 can be tolerated very well, but anything less than that will usually lead to early cataract formation. So this is a low vault. This is just about 100 microns. And this is a good vault. So if this happens, you can do an ICL exchange. Now, again, I think it's not very different from basically, explanting the ICL and injecting it again. So I'll just bypass this video since we've already seen this. Now, sometimes you will have a situation where you have a small pupil. I was going to operate this patient, and it was towards the end of my cataract list, and my staff forgot to put dilating drops towards the end. And when the patient came in, the pupil was reacting to light. So I was, in a situation because this was a toric ICL and we had to do something about it. So here I used phenocaine while I was loading the lens. I injected phenocaine, and you can see that the pupil does dilate fairly well. This was how it dilated fairly fast, and by the time I was ready to operate, it was already nice and well dilated. So this can be a nice rescue device, and you can then inject the ICL in the same way as you would. So phenocaine can be useful if you have a constricting pupil during surgery. Low vaults in the past, like when we did not have center of flow, we would occasionally see these cataracts, and now some of these patients are coming back with cataracts. Now those I had done maybe 10-15 years back do sometimes come in with a cataract formation. The biometry remains the same as what you would do in a standard lens because the ICL does not change anything. Explanting the ICL is probably the same as what I just showed you, so I don't think I'll waste time on this video. Okay, now this is a situation which you will sometimes get, and you must be really, really alert. I was referred a patient by one of my colleagues saying that, one eye has gone off really well. The other eye patient seems to have something funny happening, and the pupil was shaped like this. And, I was wondering what is wrong because with the pupil of this size, I could not make out the vault. And when we did the OCT, we found that there was no vault. So this was actually an upside down IPCL done by one of my friends. And so you have to do an OCT whenever you are in this situation. It will lead to a huge complication for the patient because my friend had explanted the IPCL, but later on, because of the contact in this area, the patient went on to develop a peculiar fibrotic kind of a cataract like this. And I had to then eventually do the cataract surgery for this patient, and which of course went off fine, but it was a little challenging. Yet the anterior capsule was broken, so we had to really work hard with this patient. Eventually patient did well. So I think it's best to be avoided, and you should check the vault post-op day 1 and make sure that you have a decent vault. If you can't make out the vault for some reason, which is very unusual, but you can do an OCT and make sure that you have a good vault. So another patient of mine who presented with a cataract, there was this lady, and this was during COVID times. She came in with almost operated 7, 8, 10 years back, came back with uveitis, attack of uveitis bilateral, and she was HLA-B27 positive, and we treated her for uveitis, and then she got lost to follow-up for a few months. Came back again with a bad attack of uveitis and with an intumescent cataract in one eye and a very advanced cataract in the other eye. So this was how it looked. I decided that I had to obviously operate upon this. Now this big PI which you see over here is because of a YAG iridotomy which was done and which expanded to become so big, as the patient healed. So it was an atrophic kind of iris. The iridotomy had been done when patient had an attack of raised IOPs, when she had come with one of the attacks of uveitis and an iris Bombay was forming. So it was a very challenging situation because there was healed uveitis. The pupil was not dilating beyond this. There was, of course, a patient was on anti-glaucoma medication. She was a young lady of around 37, 38 years old, and had been operated by me when she was less than 30. And now the challenge was that I wanted to stain the capsule. I didn't want to put in viscoelastic. So what I'm doing here is that under infusion itself, I'm trying to explant the ICL without putting any visco at this time. So I'm just trying to kind of get the ICL out of the sulcus. So under infusion with the left hand, no viscoelastic has been used. So I'm just kind of, and it's a small rigid pupil. So I'm just engaging the ICL. I'm going with my infusion handpiece under the ICL there, and I'm negotiating it out of the sulcus. So, eventually you'll manage. And problem is that it's a very intumescent cataract. I don't want to have any capsular damage, yet I want to stain it so that I can do a proper good capsulotomy for this patient. And she had high astigmatism. We were, I think, planning to do a toric ICL for her. So I managed to get this out. And once the ICL was above the iris plane, pupil plane, then I stained because I still don't have viscoelastic in the eye. So I'm going to go and stain the capsule under the ICL, and then I will wash it, and then I will put viscoelastic. So I'm staining under the ICL there, and trying to make sure that my capsule is stained. And once that happens, then I will get the ICL out under viscoelastic. And now the problem was that this came out nicely. There was not much issue with getting the ICL out. I thought I'll decompress the lens with a 26 gauge needle and aspirating some of it. Looked very intumescent. So I went in with a 26 and a lot of viscoelastic in the eye. And I thought I'll just aspirate. And then the moment I touched it, there was the flag sign. It was so tense that there was no chance for me of decompressing the lens. So eventually I had to manage it. I did manage it, and I'll take you to the end of that surgery with, sorry about that. I managed to finish off by fashioning a rhexis and putting in the lens, and it came out well. Now, when we did the second eye, I wanted to be smarter. So here we went with, in the second eye, we decided to change the technique. So I went with the femtorhexis again, which is challenging because the machine, the femtosecond laser doesn't recognize the ICL. And I'll just take you to the next stage. So this was the second eye of the patient. The vault was just about, you can see how bad the vault is now. And we had to explant this ICL. So did a femtosecond planning and with LRIs for astigmatism. And once the planning was done, the challenge is to make sure that you get the landmarks correct. The laser will not detect the ICL correctly, so it will make a mistake with checking on with capturing the entire capsule. So once the ultrasound is, once the laser has detected everything, it will check for the on the OCT, it will check for the landmarks. So this is a good application of the femtosecond laser. You can see here that I'm correcting the landmarks for the cornea first, and then also for the capsule and the iris. So here I'm getting the pupil size right, and then I'm going to check for the anterior capsule positioning. So all the landmarks have to be checked because the laser will detect them incorrectly because it does not recognize the ICL in the eye. And once you have those right, and then you have to be very careful because the laser has to fire at exactly the right plane, otherwise you will not get a continuous rhexis. So there we did this, and eventually we fired, and we found that the laser was, that's how the laser fired under the ICL. And of course, you're not worried. Even if the ICL gets damaged a little bit with the laser, it won't happen. Nothing will happen because you have to remove it anyway. But now was the challenge, and we thought that we had a good rhexis, so explanting the ICL. So I won't waste much time here. It's the usual story. You have to be very careful, put a lot of viscoelastic under the ICL as well, and then get the ICL out and pray that the rhexis is perfect. So the ICL comes out. Now there was a trick here. I think when we tried to pull this ICL out, because it was a very old ICL, hand-on-hand technique, and I had an incision of about 3.5 mm. And you can see that as I'm trying to pull it out, if I remember correctly, the ICL, one of the haptics broke. I don't remember if it was in this case. Yes, it was. So one of the haptics broke, but the ICL material had kind of, got denatured, and so then we had to go back again and catch the other ear and then bring it out. So we did have an intact rhexis eventually, and managed to treat this case and came out well. So the rest of the surgery was uneventful. So I think the take-home message is that this can happen to you, and if it happens, you have to. I'm coming to my last 3-4 slides. This was a unique case which was learning thing for us. Dr. Sudha, is it okay? I've finished my time. Actually, it's 8:30 now. Can I take 2 more minutes to finish?
Yes, please continue.
Okay. So this was a patient who was a 25-year-old male. Refraction was somewhat like this. So we went with a toric ICL. It was about -7 with 2.5, -7 with 3. And right eye had lasered. We had a lattice which was lasered, and eventually patient was planned for ICL. This was how it looked. This was all the data. So the AC depth was 2.93 and 2.9. The white to white was 11.75, 11.81. And this is the target lens which was planned for the right eye as per the nomogram. It was an uneventful surgery, but we had a slightly low vault post-op, which was about 270. So it was at the lower end of what you would like. Patient had 6/6 vision and was doing well. So in the second eye, we decided that we'll increase, because it was one of those cases where the ICL sizing could have been gone either way. So, if you notice here, it was suggesting a 12.6, but because in the first eye we had got a low vault, we decided to go with a 13.2 lens in the second eye, because we thought that we don't want a very low vault, and that is why, and this was a toric ICL, so we didn't want to make a mistake. So we increased the size of the ICL for the second eye. Again, it was an uneventful surgery, and everything went well with the surgery. As this was the surgery, and I'll just show you because it's relevant to know that the ICL surgery went off well. So everything was usual. The ICL was injected and positioned, and we did a thorough wash, and everything looked good. Patient went home, and we got calls from the patient. This was in the evening. I got calls from the patient. My staff got calls at about 2 a.m. or something saying that patient has very bad pain in the eye. We told the patient to come over and we can check. We were thinking we might have an IOP spike, but patient was from an adjoining town, which is about 2-3 hours away. And he said that I cannot come at night and I'll only be able to come next morning. So we told him to take Diamox and everything, and he reported next morning. And when he reported, it was a bit of a surprise for us. He looked like this. It was under topical anesthesia, but it almost looked like a bad retrobulbar hemorrhage. Patient said that he vomited 4 or 5 times at night in spite of the Diamox and Perinom and everything that we had told him to take. And so his vision was still, this was post-op day 1, and with a lot of lid edema, and vision was 6/9, but as you can see in the anterior chamber, there was, it was a little, the vault was good. It was about 568 microns, but the AC was a little turbid, probably from the reaction, but the pupil you can see was fairly good, but it was neither small nor big. It was mid dilated, and the pressure was almost 70 millimeters. So this was the problem, and we realized that there must be a situation. I went back and looked at my video from the surgery because we record everything. I saw that I'd done an adequate wash and no viscoelastic was left inside the eye. But so we watched, we gave him mannitol, gave him Diamox, 2 stat, then started him all the anti-glaucoma drugs. In a few hours, when pressure was not coming down, we burped the AC in the OT. And after that, the pressure came down to about 25, continued him on medication. And next morning, vision had fallen to 636. There was some corneal edema. Pressure was again 60 millimeters. And again, treated him with mannitol and everything, kept him till the evening, observed, nothing seemed to be helping him. So this looked like a Urey-Zavalia syndrome with a mid-dilated pupil, and pressures were not coming down. So we decided to take him to the OT. And we thought we'll either expand the ICL or see if there is some other situation that we can tackle intraoperatively, if there's an iris stuck or something. So we did an AC wash, and with the AC wash, we kind of made sure that if there was anything retained, we could remove it. We kind of stroked the iris and made sure that it was at the angle, it was fine, and there was no kind of iris stuck anywhere. Repositioned and dialed the ICL back into place. So I thought that we can give him one more chance of retaining the ICL because he was a very high myope. And then at the end of surgery, we did a small PI, and we made 2 PIs with the cutter, and that was left like that. So eventually the patient settled down, and this was about a year and a half back, and over about a month, the IOP settled down. Post-op 1 week, however, if you notice that the vault went down to just about 263. So we had used a bigger lens, but still this vault went down. We don't know why. And post-op 3 weeks, you can see that the vault was down to just about 40 microns. So this was very, very unusual for us, that why this would happen. And we still don't know why this would have happened, but we do know that the iris was very floppy, and this was somewhat like a Urey-Zavalia syndrome. Today, patient maintains about 6/9, but he's developing a cataract now. It's about 1 year. So after this was about 2 years back, I think. Since then, this is the final slide, and I'll stop after this. We have now changed our technique completely. We don't use viscoelastic at all for our ICLs now, for almost all of them, except rare situations like the plus powered ICL. We now do a hydroimplantation. So I'll just take you to the part where we are injecting the lens. And now we use, just like for hydroimplantation of IOL, we are now doing hydro. Now this requires a lot of experience, so I will not recommend anybody who's not done, a good number of ICLs to try this, because viscoelastic gives you that added layer of safety. But since we found that this prevents IOP spikes and all those other issues that we used to get from viscoelastic, we have switched to this technique for most of our patients, and it's very controlled. However, you have to be having a very smooth motion, because if your ICL gets stuck in the tunnel, as I told you, you will have a situation, because the fluid will keep escaping and you will then have to inject viscoelastic anyway, and you may have a situation. So it's very controlled. You can do a good injection, the chamber remains formed, and under infusion, you can position the haptics as well. And also at the end of surgery, you don't have to wash the viscoelastic. So it becomes surgery finishes in just about 2 or 3 minutes. And you can close the eye, and the next day eyes look absolutely clean, and you will never have an IOP spike, no TAS. I mean, all these things are not seen. So anyway, this has been very good for us. But again, I will not suggest that anybody try it unless you are very confident of your surgical technique, and that only then you can do this. So take home messages. I think phakic lenses have become very popular in the last 15 years. And though rare, they do have their own set of complications which you have to deal with. And I think using the right techniques for meticulous workup, case selection, and surgery can help avoid most complications. So with that, I think I'll stop and I'll be happy to discuss.
Thank you, Dr. Luthra, for that wonderful, wonderful presentation. Am I audible?
Yes, ma'am. Yeah.
So I had a couple of questions. What is your regimen for follow-up of these patients? Because you obviously must be having patients coming back from your last 15 years of practice. So what is your regimen for follow-up for these patients?
So almost all our ICL patients are asked to follow up at least once a year. Because some of them, while most of them will not develop any IOP issues or glaucoma or something, but some of them may go on to develop vaults which are going down, and some of them may have, I mean, we haven't seen endothelial issues, but the typical follow-up is, because most of them are high myopes, they all have to get a peripheral retina screening. And before they come to me in the OPD, actually my staff now does an OCT for the vault for all patients who come for post-op follow-ups. Automatically they are taken for that. We don't charge them for it, but because it's a good practice, so we just do an OCT vault. And then, so when I see the patient, I would have, so the few things that we would probably do is annual follow-up, a retina exam, a vault exam, of course the vision. And most of these patients do extremely well, but some of them have gone on to develop a cataract with the vault going down over the years.
Yes, and like you said, some of these patients their vault comes down. So is there any particular reason? Because like initial for 1 or 2 years, they seem to be stable. And then the vault, is it because some kind of fibrotic process is going on in the sulcus, or have you any thoughts on that?
I think there are two reasons, so I do remember when I started doing ICLs, there were times when I was doing ICLs for patients who were 18 or 19 years old. Now we don't do it for those patients. We wait for at least 21, 22 years before we offer them an ICL. Because a couple of my patients who were 18 when we did there, they were high myopes. By the time they were 20, 21, they had a progression in myopia. They had an increase in axial length, and probably therefore, some increase in the sulcus diameter as well. So their vaults went down. I remember one boy whom I had operated who was exactly 18 years old. And by the time he was 21 or 22, his vault went down from being 700 to just about 100 or 150. And he became about 3 diopters myopic, So that was a learning lesson. And so we've changed the minimum age for doing ICLs, number one. The second thing is that as we are growing over say 10 years, the lens thickness goes up, and the lens thickness, as it goes up, the vault will come down. So, that's why I would be very careful in doing ICLs also for anybody who's in the early 40s, late 30s, or, maybe in the age group of pre-presbyopic age group, because that's when the lens thickness has gone up and they're likely to have lower vaults as well. So these are two reasons I feel, the increase in the lens thickness and maybe progression of myopia, maybe. So and then there are certain unexplained reasons, as you saw with my case, where it went down from just about 600-700 to nothing.
It's very illuminating. So you would recommend ICL, say, between the ages of 22 to 40, ideally?
Yes.
Right. Another question that I wanted to ask you was that beautiful case you showed on how that patient had that intumescent cataract. You were not using, because the patient was having a cataract. Why were you not using any viscoelastic? Any particular reason why you wanted to avoid it?
Right. So the thing was that ordinarily I would have obviously used the viscoelastic here because I wanted to stain the capsule with trypan blue because it was an opaque cataract. So I've realized that trypan blue tends to, mix up with viscoelastic, and it gets, it makes a mess inside. And I have been quite used to doing maneuvers, including doing a rhexis and, rhexis enlargements and IL implantations under infusion, because it gives you a very stable chamber. And I use calibrated side ports, and I use calibrated instruments from the side port, including my micro rhexis forceps. So generally, I don't hesitate to kind of, if I don't need viscoelastic, I will not use it. Even a lot of patients with healed uveitis with synechias and everything, if I'm operating them and I need to kind of release the synechias, if there's a, like a say seclusio pupillae or a occlusio pupillae, I will not use viscoelastic. I'll just form the chamber with infusion with my left hand, and with my right hand, I will go and release everything. And then once I have a pupil stretch and everything, then I will stain. And then in the end, I will put viscoelastic. So that allows me to do everything before putting the viscoelastic, including staining the capsule.
Yes, that sounds really like a good plan. Yeah, I think that's about covers. Anybody else wants to ask any questions?
Yeah, Madam, I wanted to ask something. Anita here.
Yeah, go ahead.
Yeah, good evening, Dr. Gaurav. Dr. Anita Jabbar here. Sorry, my video is off. I cannot help it. And that was a very beautiful presentation. Lot of tips and take-home points. I wanted to discuss about this case, which I did 4 years before. Actually, that lady was from Oman. It was a pre-COVID area. She was a keratoconus patient, post C3R. 1 year back, she came back for ICL. So what I did, what I remember was, I found it very difficult to unfold the lens. It was a star ICL. So what difference the technique was, I used cohesive. That is what I remember. I used a cohesive viscoelastic, but the unfolding of the lens took some time. But the surgery went on well, and she went back happily. But 1 month after following the surgery, she started sending me pictures. Lot of iris pigment dispersion, and the color pigment brownish coloration over the center of the ICL. So, any points on this?
So did it happen in both eyes? Was it in both eyes?
Yeah, it was in both eyes. I remember left eye was worse than the right eye. Even the vision was 6/6 immediate post-op. 1 week she was with us. After 1 week she went back. Vision had dropped to 6/12 or 6/18 or so.
So I will not think that this would have anything to do with the keratoconus, really. I mean, I'm not sure that there would be anything to do with the keratoconus part. But as you're saying, we've had one patient over the last 3-4 months itself, where patient had anisometropia, and one eye was like -15 and the other eye was -7 or 8. So this patient, we did smile on the eye with the -7 or 8 because he was not keen for an ICL, and after a lot of counseling, he agreed for the ICL in the fellow eye. So in the fellow eye, we did the ICL, and in the ICL eye, over a period of 3 to 4 months, he lost pigment just like your patient, and he went on to have a total difference in the two eyes as far as the iris color was concerned. The eye with the smile retained its normal iris coloration, and we have documented it and we are publishing this. So we found on gonioscopy that the angle had a lot of pigment, and this eye with the ICL lost pigment, and everything was perfect. I mean, there was no reaction otherwise. There was the ICL vault was fine. Everything seemed perfect. And yet this patient continued to lose pigment. Now it's stabilized, but we can see an obvious difference in the coloration of the two eyes. So some eyes, may be prone to kind of, have a pigmentary kind of the pigment dispersion kind of a situation with a ICL in the sulcus. That's all I can think of. Did your patient also have IOP spikes, or because patient was abroad, you could not see the patient?
No, Dr. Gaurav. She was sending me the reports. The IOP, everything was okay.
Okay, so our patient actually had some IOP spikes, not bad ones, which was controlled with medication, and now he's off medication. But for a few months, we had to put him on medication, and this was it. But I don't have an answer because this is the closest that I have to your patient's situation, that sometimes the phakic lens may kind of cause these kind of situations where there may be, pigment dispersion and situation like that. But would have to be managed. I don't know if your patient had inflammation or cells or anything else along with the pigment dispersion. To whoever
she was on Predfort. I used to give her Predfort.
Did that help? Like when the patient was having all these problems, giving Predfort, was it working for her?
No.
And eventually, what happened to the patient? Like finally, how did it settle?
Eventually, she came back after 1 year. She came back, By that time, the pigment dispersion, there was no active, but you can make out the coloration.
Right.
And
Also,
the
there was
vision
some
was
iris dyspigmentation, like was the hypopigmented iris and
no.
Mm.
Pupil was round. Everything was okay.
Right, right.
Somehow reassured and sent her.
For our patient, there was a stark difference because we had done only one eye ICL and one eye was smile. So we had such a huge difference. And I don't know if I have those pictures on my laptop, but I don't know how to find them right now. But it was quite remarkable, and we still don't know why this happened because everything in that patient is fine otherwise. Anyway.
No, I wanted to ask you, was there a cluster of cases like that, like difficult in unfolding, like any manufacturing?
Not for me. No, I have not had this situation at all. In fact, these ICLs typically open fairly fast. In fact, if once you've kind of injected them all the way, they will open up almost.
Yeah, that was the most easiest
But
part.
I haven't come across this situation, ma'am. No.
Okay. And about that hydro, without the last case where you were showing, that hydro assisted.
Yes.
So you can use an AC maintainer?
Yes, you can.
Okay.
Absolutely.
Yeah.
That would be another great idea to do. In fact, the only thing I would think is that AC maintainers, unless they tend to push less fluid than what a infusion handpiece will do. So somehow, when in the past, when I've tried to use an AC, not for ICLs, but for certain other situations, I've not had enough, like the chamber stability is not that great. So I've had to supplement it with the infusion in my left hand. But definitely, if you have a good AC maintainer, and nowadays, they are making with the thicker bore and thinner walls. So an AC maintainer should work equally well.
Okay, sir. Okay. Very, very fortunate to hear from you. Thank you.
Thank you very much, sir. Can I have a basic question?
Sure, ma'am.
Okay. Which is technically more easier, whether it is ICL or IPCL? Any difference in technique?
Okay, so I'll answer this. Sure, ma'am. I'll answer this in a simpler way. The loading of the IPCL seems to be much easier because, it's just like a regular IOL that you have to kind of load it. The cartridge is the same. So it's much easier to load the IPCL as compared to the ICL. Yet, injecting them also, I would think that both are almost equally good, but maybe the predictability of the ICL opening up is much better for me than the IPCL. The IPCL tends to sometimes flip more often while you're injecting it. It tends to rotate more often. So yet it's not been a problem because as you realize that IPCL, as you're injecting it, and if you realize that the landmarks are wrong, you can rotate it very easily inside the eye before you have delivered it completely. Whereas the ICL, you cannot rotate it. Once even more than half of it has gone inside, you can keep trying to rotate the cartridge and nothing will happen. It does not rotate that much. So frankly, it's a mixed bag. But I would definitely think that, that should not be the deciding factor for you. And, if a patient can afford it, ICLs have been around for almost 15, 16 years. I would still choose the Star ICL over this. But IPCLs have really improved over the years. And some of my friends, I think Dr. Rajesh Sinha has done a study even for the, the upper lens, which is available. I have not used it. He has had good results with that. And there is a biotech ICL also, which is available, which I've used a few times, and that's also good. But I have maximum experience with the IPCL amongst the Indian lenses, and I've found excellent results. The refractive predictability is very good. And, these patients tend to get great visual outcomes as well. So far over last 4 or 5 years that I've used the IPCL, I have nothing to complain. Okay. The only thing I do notice is that the optic size sometimes is a little smaller as compared to the new Evo Vision ICL. So very rarely in a high vault IPCL, I will get an kind of like an optic capture. The edge of the pupil will sometimes catch the edge of the optic. And these patients, then sometimes you have to maintain them on, I usually maintain them on IOTIM Plus because that keeps the pupil small and gradually the vault goes down, as ma'am just said. So over a few months or maybe a year, sometimes when the vault settles down, then this thing stops happening.
Okay, thank you very much, sir. Rajendran sir is doing a lot of ICLs, no? Sir is here.
One more thing, ma'am, I'll want to add. IPCL, the good thing is you can order them to be implanted at 180 degrees. So they will send it to you as 180 degrees. So it's very easy for anybody to, mark out the 180 degrees, because in ICLs, you will have to rotate them if you're doing a toric ICL to position them. Whereas in IPCL, you'll just implant them at 180. So all that makes things a little easier for any cataract surgeon to graduate to phakic lenses.
Sir, I'm Dr. Vijay George. I have a small doubt. Sir,
Sure.
while you are implanting the ICL under hydro, you're using the routine the irrigation port in the left hand?
Absolutely. Yes.
The
I'm using
same.
it. Yes.
Okay.
The only thing
And
is, I will just qualify it by saying that I use a calibrated instrument. So my side ports are made exactly to 22 gauge. That's 1 mm. And my infusion, I've also designed these IA handpieces with Epsilon myself. So they perfectly fit my incision. So there is no wound leak. So my chamber is going to be very stable. So both my irrigation and aspiration handpieces are calibrated to my side ports. So when I use these instruments, I will have no leakage happening from my side port. So my chamber will be very nicely formed. That's very important. So the infusion flow should be high and you should not have a leaky side port. Otherwise, you'll keep getting shallowing of the chamber.
even through the main port, there won't be any leakage, no?
No, there will be leakage, but once the ICL kind of reaches the incision site, then the leakage stops. So you should not have a very loose wound and you should not have a very tight wound either. So once you have a 3 mm incision, which I use, I don't have leakage from the main port. Once the ICL has reached the tip, initially when you start injecting, there will be some leakage, but by the time your ICL reaches the tip of the cartridge, the leakage stops and your chamber becomes nice and big, nice and full. But then, the moment your ICL is delivered inside and you are going to withdraw your cartridge, you have to be very careful, because if your ICL part of it is still inside the incision, the chamber will suddenly shallow. So that time you have to be prepared to kind of, with the cartridge tip itself, push the ICL so that it goes inside, and the moment it goes inside, your chamber will be formed. As I said, it's a little tricky to do this. So after you've done a couple of hundred of ICLs with the viscoelastic, then you can, do these things more easily.
Okay, sir. Right.
Is there any role for doing specular microscopy also frequently as a follow-up measure?
Ma'am, we do specular for all our refractive surgery patients pre-op.
Pre-op.
And for ICLs, we were doing it for the last so many years. The thing is that we haven't found, initially when you do an ICL, there will be a fall in specular counts over the first 2-3 years, more than usual. But after that, it tends to stabilize. So what we found is that, we've stopped doing it now unless we suspect that something is not right. But as a rule, we don't. And if somebody comes back after many years for a follow-up, sometimes patient comes back after 7-8 years, then we'll do a specular. But if a patient is following up every year, we will not do it on every visit. We might do it once in 4-5 years. But the trend is that they will have the specular counts falling more fast in the first 2-3 years of surgery, and then they don't fall as fast. But yes, by 10 years, you can imagine that just like a cataract patient, there will be a fall in specular counts.
Thank you.
Sir, one more question. So previously we were using Pilocar. Now I'm using Myocol. Is it contraindicated? Why don't you use it?
No, there's no contraindication. In fact, it's absolutely fine to use it. It's just that, we end up doing mostly toric ICLs now. And, if you constrict the pupil and if the ICL rotates towards the end of surgery as you're hydrating the wounds and everything, you will not realize it. So that is one reason. And second thing is that if you are confident of your foot plates having gone behind the iris nicely and not catching the knuckle of iris, which over a period of time you do become good with. It's just like cataract surgery. Today with Phacos, we don't put pilocarpine. And in the past, when we were doing our extracapsulars and other surgeries, we used to always put pilocarpine at the end of surgery to constrict the pupil, or even with our intracaps and everything. And today almost in cataract surgery, because sometimes with pilocarpine, patients will complain of pain at midnight. They have, they'll complain of a sudden episode of pain at night, and they will be uncomfortable. So unless there is a reason, yes, occasionally if I have a patient who's getting an optic capture or something with an IPCL, sometimes I will put a drop of pilocarpine, but very limited, and I'll wash it out immediately once my pupil is a little bit constricted. But I don't want to leave a very small pupil for sure. Okay. But Myocol is absolutely fine, and you have to actually suit your own convenience. If you're happy using pilocarpine and Myocol, there's nothing to stop you, sir, from using it. And it's just that over the years, I realized I didn't need it. So I try to be minimalistic with my surgery. For example, I don't like to use viscoelastic anymore. So I only use it at the time of rhexis, and after that, there is no viscoelastic. And I feel that my eyes are much cleaner like that. So same way, I don't use too many things in the eye as far as I can.
Yeah, Anita here again. Dr. Gaurav, the center flow ICLs, they don't recommend even YAG PI, no? Preoperatively.
Sure, yes. We don't.
But I have some colleagues who does surgical PI. intraoperatively. Do you
Now
recommend?
I don't think I haven't done a PI in the last 7-8 years except for spherical ICLs. So sorry, for hyperopic ICL, because they don't have a central pool. So but otherwise, both with IPCLs and ICLs with the central flow, there is absolutely no need to do a PI. I haven't had an instance of a pupillary block happening if you are washing the viscoelastic out thoroughly. Only if you are not very meticulous with the visco wash, which will have a lot of problems, because if your visco is there, you'll have IOP spikes. You may have even some anterior capsular opacification sometimes, because it takes ages for it to clear up. And we have had one instance where the centra flow was blocked by the viscoelastic, and it was causing IOP spikes and a little bit of a pupillary block. And we sorted that out by hitting the central hole with a small shot of YAG laser, and it's resolved completely. That was so amazing, because we kind of were not able to figure out why this patient is having a little bit of a pupillary block. So we don't do PIs at all. Not now. I don't think it's needed.
So which viscoelastic do you use?
I use
Dispersive?
hydroxymethyl cellulose. Some of my friends have started using sodium hyaluronate. They think that it comes out much faster as a bolus and retains the space. But I have stuck to it, and frankly, as you know now, that I'm not using viscoelastic at all last 2-3 years.
Okay. Thank you.
But if I had to use, I would still stay with hydroxymethyl cellulose.
Okay. Thank you.
Gaurav, what about that last case? Was a very interesting one. You were talking about that Zurich-Zavalia syndrome. What is that actually? Iris strangulation. So
no, it is like, Urich-Zavalia syndrome can happen with, patients where, they have IOP spikes with pupil, sphincteric, like mid-dilated kind of a pupil. And usually there is a situation where, because of the very high IOPs, and there will be misdirection kind of a thing of the, what do you call, at the ciliary body, and they will have, these patients will have a very severe kind of pupillary, they will have mid-dilated pupils which are not going to react. And usually it has to do with the root of the iris sometimes, where you can kind of do a stroking maneuver. So Dr. Amar has been talking about doing single pass orthopupilloplasties for these patients with Urich-Zavalia syndrome as well, because that tends to kind of pull the iris out of the, from the root, and resolve the pupillary block kind of a situation which happens. And this patient which I had actually had a very floppy iris. If you noticed in the second surgery that I did, because see, when I did the ICL, the pupil was fully dilated, so I didn't realize that there was anything like this. But when I went in for the second time and I was trying to do the AC wash, the iris was lumpy. It was almost like a very floppy kind of an iris, which you will see in a, this floppy iris syndrome. So maybe those irises are more prone to get this Urich-Zavalia. Even keratoconus patients are known to have this occasional situation where if you dilate them, then they will have a pupil which will not come back, and they think that there might be something like a Urich-Zavalia syndrome. So it's extremely rare, and I was kind of unlucky to get this in this patient out of the blue. But it has been reported, and when we looked it up, we found 4 case reports of Urich-Zavalia syndrome following ICL implantation.
Dr. Rajendran, would you like to say something? I think he's here. So is everybody doing phakic lenses? Like, is it very popular now in your area? I mean, a lot of surgeons doing it. I'm sure they are, because now, it's become so easy to access them, and patient acceptability is better. The numbers are growing. We are doing ICLs even for very small corrections now. So anybody with a suspect cornea who comes in for a laser refractive surgery, and if is not fitting in for any kind of laser procedures, we go ahead. Or even with a suspect cornea, we don't hesitate even at 3 or 4 diopters of myopia to go ahead with an ICL now. This thing, I mean, not an anterior segment surgeon, I would say, like, it looks a little, when you're doing all this rotation, what doesn't it cost? We are doing, but not for very low powers. But mostly we do it about here, at least in my practice, about minus 6 diopters. That's very good, actually, because see, in the past we were doing ICLs only. Like when I started doing ICLs, we used to do it for patients with more than 10 or 12 diopters, and we were happy to do LASIK for up till 10 to 12 diopters. Today, I'm very reluctant to go to those high powers, and thresholds are much lower, because we understand that the cornea can get compromised, and our comfort with ICLs has improved so much over the years. And so again, as you are saying, that beyond 6 or 7 or 8, if a patient has a borderline cornea, I will not hesitate to
shift to an ICL. But sometimes you have a suspect cornea, you don't want to do anything on the cornea. Then even with the small corrections of 2 or 3 doctors, we've gone ahead and done an ICL instead rather than compromise the cornea. So I guess an overdose of ICLs just now.
No, it's a lovely video. I think it's a one of the rare topics done here. So I think for everybody, it's a new, and so much has been done by you. And it's not tips and tricks. We should have actually started off with the basics.
I thought that I could have gone. I had a lecture which was totally on how to start ICLs. Maybe that would have been, I don't know.
Yeah, we can do that next time. We'll call you again.
Sorry. Maybe I bored everybody with like
no.
But
I think,
for people who are doing ICLs, these small little things would be.
Really.
And I'm doing actually my AIS course is on how to add ICLs to your practice, and that's for cataract surgeons to start doing ICLs even if they don't do laser refractive surgery. So
give us a link. We will definitely. I'll post it in TACO next time, and KSOS. Definitely, I'm going to call you again for this.
Sure.
Thank you so much. And I think, Merin, can you just conclude the session?
Yes, so I think this was a wonderful session, and really I must congratulate Sudha for having chosen such a, erudite speaker. And even though I think the last 2 years back we had a similar session on ICL, Dr. Alpa Atul had spoken on ICL. She had come down here. And that, I don't know whether you remember it, Sudha, but we had this initial how to start ICL we have already done actually. But anyway, I think Dr. Luthra has covered it wonderfully. So on behalf of TACO and all my colleagues here, I would like to thank you once again for having graced us here and shown us all these wonderful videos. And looking forward to having you here again in TACO. Thank you, Doctor.
Thank you so much, ma'am, and thank you everyone for inviting me, and especially Dr. Sudha, back from my GNEC days. So it was a pleasure to be here with all of you. And someday, maybe physically, I can come and attend one of your meetings in a year or two, and that will be even more, great. I mean, it'll be nice.
Wonderful. Sujata, what do you do?
Good evening, ladies and gentlemen. It's indeed my pleasure to offer a vote of thanks today. I thank Dr. Gaurav Luthra for his wonderful, excellent presentation and also for sharing those instructive videos. Thank you, sir, for joining us today and for the wonderful session. I thank Dr. Merin, Dr. Sindhu, and Dr. Rajendran for chairing the session. And I also thank Dr. Anita and Dr. Vijay for joining and providing us a wonderful discussion. And I also thank all the members and the senior faculty for joining us today. I thank Dr. Tanu for the technical support. I thank the KSOS for providing the Zoom platform. I thank you all, each and everyone once again. Thank you.